name is Sengupta. I'm a gastroenterologist at the University of Chicago, and it's my pleasure to speak about building a quality colon cancer screening program. So my objectives in this 15-minute presentation are to review current colorectal cancer screening recommendations, and then I'll review kind of colonoscopy quality metrics and the priority QI measures that are important to record for colon cancer screening. And then I'll finish by providing some tips on building a high-quality, non-invasive screening or colonoscopy program. So let me begin by stating that colorectal cancer screening is working. It is a success story. What we can see here is that the overall mortality for colorectal cancer screening has been decreasing over time. And at the same time, the incidence of local, regional, and metastatic colorectal cancer has been decreasing. Much of this decrease has occurred with widespread uptake in screening in the last 20-30 years. And so a significant component to the decreased mortality and incidence is thought to be attributable to the screening effect. So let me begin by talking a little bit about current American College of Gastroenterology screening recommendations for colon cancer screening. There are two tier 1 screening options that are recommended. The first is a colonoscopy to be administered every 10 years in patients who are at average risk for colon cancer. And the other option is the annual fecal immunochemical test, or FIT test, which is a non-invasive option. FIT testing is a 2-step test. If negative, then patients need to have it done annually. If it's positive, then a positive FIT needs to be followed with a timely colonoscopy. The tier 2 options, which are mentioned, are a virtual or CT colonography every 5 years, FIT fecal DNA testing every 3 years, flexible sigmoidoscopy every 5 to 10 years, or colon capsule every 5 years. For the purposes of this talk, I'm going to focus on colonoscopy and FIT-based testing, since they're the two most widely used screening options in most countries. Colonoscopy, as most gastroenterologists are aware, has the highest sensitivity and detection for both colon cancer as well as precancerous lesions, and thus it can both detect and prevent colon cancer by removal of precancerous or adenomatous polyps. 1 to 2 negative colonoscopies essentially confer a lifetime of colorectal cancer prevention. And for patients who have normal exams, they can go many years in between screening examinations. Although randomized controlled trial data are lacking, there are several cohort studies that have suggested that colonoscopy is efficacious in preventing incident colorectal cancer. However, colonoscopy does have some disadvantages as a screening tool. First of all, it's a procedure, and as such, it carries some associated risks. Those risks include bowel perforation, aspiration, or bleeding. Most of those risks occur in the setting of polypectomy or removal of precancerous lesions. Importantly, colonoscopy is really only effective with a complete and kind of thorough bowel preparation, and it requires a split dose prep. There's really limited benefit to doing a colonoscopy without a complete bowel preparation. And then really most importantly, colonoscopy is an operator dependent test. It really depends on what an individual endoscopist's performance is to determine the benefit of that colonoscopy. And there are established QI metrics, which I'll discuss, that are associated with an individual endoscopist's risk of post-colonoscopy colon cancer. In terms of the advantages and disadvantages of FIT testing, as a non-invasive test, FIT is clearly cheaper. It has a reasonable one-time sensitivity for cancer at about 80%. And for providers who offer colonoscopy to patients that they refuse, FIT testing is considered an excellent second choice. And importantly, bowel preparation is not required for performance of FIT testing. However, FIT testing has limited sensitivity for advanced adenomas. It requires annual repeated testing to really boost that sensitivity up. And there is poor to limited sensitivity for serrated polyps and serrated precursors. Most importantly, the only benefit of performing FIT is to follow it with a colonoscopy if the FIT is positive. There have been several studies showing the risks of kind of colon cancer with a positive FIT. This was a recent study published in Gut, which looked at patients who had a positive FIT test, and then they were either compliant with post-FIT colonoscopy or non-compliant. And what we can see is that the overall risks of mortality increase significantly over time for patients who are non-compliant with getting a colonoscopy after a positive FIT. So thus, failure to complete a timely colonoscopy after a positive FIT markedly increases the risk of dying from colorectal cancer. And then additional studies have actually shown that an increased time to colonoscopy after a positive FIT is associated with a higher colorectal cancer incidence, death, and late-stage colorectal cancer. And thus, most societies suggest that we should really be doing colonoscopy as soon as possible, at the very least within 6 months after an abnormal FIT testing. There's been a lot of recent kind of excitement over the increasing incidence of colon cancer in younger patients in this country, in the United States. Several studies have shown that the incidence does seem to be increasing for younger patients, and the precise kind of mechanistic underpinnings for that are to date a little unclear. However, most recently, the US Preventative Task Force Services changed screening guideline recommendations to 45. So here are the kind of age-based recommendations for screening for the American College of Gastroenterology. The ACG recommends screening at age 50 for average risk patients. They strongly recommend screening beginning at age 50, but also suggests that we can begin screening at age 45 as well. So currently, we are recommending that we screen patients 45 or older for colon cancer with either a FIT or a colonoscopy. The topic of when to stop screening is also important because oftentimes we are doing inappropriate colonoscopy in older patients. The most recent society-based guidelines suggest that a decision to continue screening beyond the age of 75 really must be individualized. And for patients who are up to date with screening, who have had prior negative exams, particularly have had prior negative colonoscopies, we should really be stopping colonoscopy at age 75 or when the life expectancy is thought to be less than 10 years, primarily because the benefits of removing polyps likely are outweighed by any potential risks of the procedure. However, patients who've never been screened should be considered for screening up to the age of 85, depending on considerations such as their age and overall comorbidities. Family history is a really important component of colon cancer screening. The most recent guidelines recommend that if an individual has a family history of colorectal cancer or advanced adenoma in 2 first-degree relatives diagnosed at any age or 1 first-degree relative under the age of 60, those patients should undergo colonoscopy beginning at age 40 or 10 years before the age at the diagnosis of the youngest affected relative. And those patients should be undergoing colonoscopy every 5 years. However, patients who have a family history of colorectal cancer or advanced adenoma in 1 first-degree relative at any age over 60, they can begin screening at age 40 or 10 years before the age of diagnosis of the youngest affected relative. But then the options for screening and intervals are going to be the same as an average risk person. Let me transition to talk about the importance of measuring quality in colonoscopy. So measuring quality is very important for 3 reasons. First of all, polyps are frequently missed. As I mentioned, colonoscopy is an operator-dependent procedure. And I'll show some data showing the frequency of how often polyps are missed. Second, polyps are incompletely resected by gastroenterologists and endoscopists. And then finally, patients are often given inappropriate surveillance recommendations. High-risk patients oftentimes do not have a colonoscopy done in a timely fashion, and this can lead to underutilization of colonoscopy, which can lead to new lesions. On the flip side, Low-risk patients often have colonoscopy overutilized, where we're doing more frequent colonoscopy for no clear benefit. As I mentioned, polyp miss rates are surprisingly high. This was a meta-analysis of tandem colonoscopy studies, quantifying how frequently missed polyps occur. And what we can see is that the overall adenoma miss rate is 26% in the systematic review and meta-analysis. Kind of shockingly, the advanced adenoma miss rate is as high as 9%. And what we can see here is the miss rates clearly vary by size of polyps. So smaller polyps are very frequently missed, up to 28% of the time. And then similarly, polyps in the right side of the colon can be missed 17% of the time compared to left-sided polyps, which are missed 9% of the time. These miss rates can be reduced by improving the quality of the bowel preparation and using auxiliary techniques such as retroflexion or using devices on the tip of the scope. So current recommendations are that all endoscopists and endoscopy centers who are performing screening colonoscopy should measure individual adenoma detection rates, cecal intubation rates, and withdrawal time. And these are strong recommendations based on the available evidence. The American College of Gastroenterology recommends that colonoscopists who have an adenoma detection rate below the minimum threshold, that's considered 25%, should undertake some sort of remedial training to improve their ADR. The guidelines also recommend that colonoscopists spend at least 6 minutes inspecting the colon mucosa during withdrawal of the scope. Now, withdrawal time has been clearly linked to post-colonoscopy colon cancer, with individuals who have withdrawal times less than 6 minutes. Those individuals have a much higher rate of post-colonoscopy colon cancer. And then finally, the colonoscopist should strive to reach the cecum at least 95% of the time. This was a pivotal study really showing the benefit of having a high adenoma detection rate. In this study, based in the Kaiser population in the US, endoscopists were stratified into 5 different quintiles of their adenoma detection rate. And what was found was that patients who were in the higher quintiles had a significantly lower rate of interval cancers. And the flip side was true for patients in the lowest quintile of ADR. They had the highest risk of interval cancers. I mentioned that bowel preparation quality is really important in achieving a successful colonoscopy. So bowel prep quality should be measured by centers, and the overall percent of kind of adequate prep quality is really considered the frequency with which a bowel preparation is adequate in order for us to use the recommended surveillance or screening intervals. And the overall recommended target is that we should be achieving an adequate bowel preparation approximately 85% of the time or higher. If you are not achieving that rate, that means that we are not doing something correctly and we need to change the way we prep patients. And split dose or same day bowel preparation has been shown in multiple studies to be superior to the day before bowel prep. So split prep should be prioritized for outpatient screening colonoscopies. In terms of procedural safety, there have been established kind of targets that should be kind of not achieved, but we should be hitting less than these predefined targets. So perforation should occur less than 1 in 500 for all exams, but specifically for screening exams, perforation should occur less than 1 in 1,000 times. And overall post-polypectomy bleeding rate should be less than 1%. In order to kind of measure these metrics, we need to systematically capture patients who have complications. So that's really recommended for a high quality screening program. So just some general tips on building a high quality colon cancer screening program. So some general points. First of all, multiple studies have shown that organized screening is superior than opportunistic screening. Examples of organized screening can include mailed outreach to patients with a FIT test, or kind of systematic reminders for providers to reach out to patients to order a colonoscopy. They have been shown to overall increase the uptake of screening in communities. Interventions that have been shown to work include patient reminders, either through mailed outreach or even through text messaging,